Hi, everybody. My name is Matt. I am a 11-year papillary thyroid cancer survivor from Seattle, Washington. And this session is titled Precision Medicine in Thyroid Cancer, the Role of Molecular Diagnostics in Optimizing for Thyroid Cancer Patients with Theodora Pappa. Dr. Pappa is an onco-endocrinologist and physician scientist committed to precision medicine in thyroid cancer. Her clinical practice is at Brigham and Women's Hospital, Dana-Farber Cancer Institute, is thyroid focused, and she conducts translational research on thyroid cancer genomics. Dr. Pappa is a 2022 ThyCa research grant recipient. And with that, I introduce Dr. Theodora Pappa.
Be here with you today and also connect with everyone through Zoom. So today, this session, we will talk about the role of precision medicine in thyroid cancer and how we can leverage molecular diagnostics to really optimize care for patients with thyroid cancer. And just to give you an outline about the items we're going to talk about, we'll talk about how we are using molecular testing to diagnose those indeterminate thyroid nodules and understand the risk of cancer. We're also using molecular testing for prognostication and really stratify the risk of disease. Another subject we'll talk about is how molecular testing can guide selection of targeted therapies in advanced disease. And then what role it may have in redifferentiation strategies. We'll briefly touch on some more rare subtypes of thyroid cancer, such as oncocytic and kinase fusion-related cancer, and discuss how molecular testing can help identify mutations as a potential mechanism of resistance to therapy. And for the last part, if there's time, I'll talk about the broader implications that molecular testing can have, even in conditions outside the thyroid, and indications to refer patients for germline testing, so testing for mutations that are present in all the cells of our body and can be transmitted to our offspring. But before we get started, and because it's going to be a technically heavy session, let me start with a couple of terms about what is a mutation and what is a copy number alteration. These are terms that I'll be talking frequently about during this session. So our body has cells, and each cell has 23 pairs of chromosomes. And each chromosome is an X-shaped structure that you can see on the graph on the right that contains DNA. It contains the code, like all the information that the cell needs in order to function. And so when we have a small change in a segment of the DNA that we call a gene, that is called a mutation. And then if we have multiple or fewer copies of certain sections of the DNA in that chromosome, this is what we call a copy number alteration. And both of these molecular events are actually very common in cancer. Sure. Me? Okay. I can talk in the microphone.
What about this microphone?
Okay. Maybe there's echo now? No. Okay. So let's start by talking about the increasing role that molecular testing has in understanding the risk of cancer in thyroid nodules. So most of the time, a typical presentation is that the patient presents with a thyroid nodule, and the next step is that they have a fine needle aspiration biopsy guided with an ultrasound. And then a cytologist look at the cells that are obtained from the biopsy. And these are the different figures and the different images you can have under the microscope, the different categories that we call Bethesda categories about what the cytology may look like. And then there's the ends of the spectrum. So the cytology may return benign. So good news, the risk of cancer is very low. We can observe that nodule, no problem. And then there's the other end of spectrum where the cytology returns malignant. We have a definitive diagnosis, and then surgery in most cases is the next step. But however, there's also two categories, category 3 and 4, and that's an appreciable number of patients with thyroid nodules that end up with those cytology results, where the risk of malignancy can vary anywhere between 10 and 40%. So that's a wide range. And in the past, we didn't really have many tools, and almost all of these patients would end up having diagnostic surgeries, and then some of them ended up having benign results. So now we have the luxury of having molecular testing that can help us better understand what the risk of cancer is in these nodules. Nope. It's not working. I can. Okay, I'll use that. And so actually the role of molecular testing is incorporated in the newest 2023 Bethesda system, so the system that cytopathologists use when it comes to reporting the cytology results of thyroid nodules. And you can see here that there's a role for molecular testing in both Bethesda category 3, that's when we see results called atypias of undetermined significance, and also category 4, which is the follicular neoplasms or suspicious for follicular neoplasm. But there may be also a role for Bethesda category 5, and I'm going to talk about that. So what is the benefit for doing molecular testing? So the thing is that if you end up with an indeterminate nodule, now you have the option of proceeding with a molecular testing. And then if that turns out to be benign or negative, it is safe to say that you don't need to operate and you can continue observing that nodule. So actually, you avoid unnecessary surgery. And when studies have been done with molecular tests that have been very well validated, Afirma and ThyroSeq are two examples of these that we commonly use, up to 49% of patients could avoid diagnostic surgery. And you can see on the right here a diagram of a study where they studied 348 indeterminate nodules. They compared two molecular tests. They both performed very, very nicely. But the take-home message from that study is that out of those 348 indeterminate nodules, over 180 of them could be safely observed, and patients could ended up avoiding surgery. So that's impactful. The other thing is that such an approach can also be cost-effective, and studies have analyzed what could be the average expected cost of using the molecular testing strategy, and then if needed, and if surgery is indicated, including that cost. And so that rounds up to about $14,000 to $18,000. And that's compared to an average expected cost of proceeding straight with diagnostic lobectomy. That's about $38,000. So that's a big difference. Obviously, we practice medicine nowadays taking into significant consideration our patients' preferences. So at the end of the day, there's counseling that needs to happen and shared decision-making to make the best plan forward. So besides having molecular testing help us understand the risk of cancer, it can also help us gather prognostic information and help us tailor our treatment strategies. And what I mean with that, I'll give you an example. A patient comes with a 2-centimeter thyroid nodule on one side of their thyroid. A molecular test is done, and then it shows a BRAF V600E mutation. So now we know that this mutation, this change in the DNA, has a sensitivity over 95% to be papillary thyroid cancer. And based on the latest guidelines from the ATA, it's associated with what we call an intermediate risk of recurrence. So now, because this mutation, and I'll give you some slides later on, is such a common event, it's present in 60% of all papillary thyroid cancers, it should not be used in isolation to make us want to proceed with more aggressive therapy. And to the clinical point of this, let's say this patient has only one nodule. There's no nodules on the other side of the thyroid. There's no suspicious lymph nodes in the central, the lateral compartments of the neck. We don't need to pursue total thyroidectomy because there's the BRAF mutation. These are patients that could safely proceed with a lobectomy, at least as an initial step. So Now, I've talked about BRAF, and I think most of you attending this session today have heard the word BRAF, but did you know that there's not only BRAF V600E, there's actually 3 classes of BRAF mutations. The BRAF V600 is the most common in papillary thyroid cancer, and it's the most aggressive one. However, there's class 2 and 3, so there's other flavors of BRAF mutations, and they tend to behave less aggressively. They're not as common. But as an example, going back on a patient case, let's imagine that molecular testing comes back and shows another type of BRAF mutation, like the BRAF K601E, and these are confusing names. We know that this specific mutation sometimes is found in an entity that's called NIFTP. Maybe some of you have heard of this. This is an entity that we used to regard as cancer some years ago. We no longer think that this is cancer. It's a tumor that we've done studies, and we know that it has a very indolent potential. At this point, the only way to really diagnose this particular entity is by taking the tumor out and then testing for it. But just to tell you how important it is to review these findings, the molecular testing with a provider, and receiving appropriate counseling and about what they mean and what's their clinical relevance. On the flip side, if we have a nodule that's found to harbor the BRAF V600E mutation plus another mutation, and I'll bring an example that's called third promoter mutations. Some of you may have heard of this already. This is considered a high-risk alteration. So the combo of the two now makes us think that this is a higher risk of recurrence cancer, and we may want to take a more aggressive initial upfront strategy. And then there can be other changes in the DNA or combos of mutations, for example, having a RAS plus a third mutation, or having other changes. I'll give you some names: the TP53, PIK3CA, AKT1 alterations, and I'll show them in the slides next. So knowing about the presence of those high risk alterations may be used to alter our recommended management from the get-go. That being said, we don't have that many studies at this point. So this information, the genomic information, at this point should be used with caution when it comes to clinical decision-making. So where did we get all this information about what types of changes the tumors, the papillary thyroid cancers have? A seminal study that really advanced our understanding about the landscape of papillary thyroid cancer is the TCGA study. It's about 9 years old now. So in that study, they assessed almost 500 papillary thyroid tumors, and they did what we call next generation sequencing. That means they mapped all the code of the DNA of the tumor cells, and they found that there was BRAF mutations in 60% of thyroid cancers. As I told you, that's the most common alteration, and you're seeing that in the graph here. And then the second most common alteration were RAS mutations. So together with BRAF, they comprise about 3/4 of the mutations that we see in papillary thyroid cancer. Another important finding from that study is that it was able to eventually identify driver mutations in 97% of tumor samples. So really increased our understanding about what drives oncogenesis in papillary thyroid cancer. Now you may ask, why do we care if a tumor has a BRAF mutation or a RAS mutation or another type of mutation? So we do care a lot. Depending on the type of mutation, these tumors may appear differently, as you can see in these pathology slides, under the microscope. So the pathologist may also suspect the driver mutations by looking at the slides, but they also work to activate all these downstream pathways, all the molecules that are needed to feed the tumor cells in different ways. And as you can see in this graph, on the left side, when you have a BRAF V600E mutation, you have a revved up MAPK signaling pathway. So you make all these proteins that will make the tumor cells to continue to divide and proliferate and grow and prevent them from dying. So it does have clinical implications about the behavior of those tumors. Now, with the plethora of genomic data that we have, we're at the point that we can investigate and even more precisely categorize tumors, even those that have a common driver mutation. So this slide talks about a study that we did at Brigham and Women's, where we looked only on papillary thyroid cancer with the BRAF V600E mutation. So this, one could say, kind of represents a homogeneous cohort. So we studied 225 of those tumors that had the BRAF mutations, but then found that some of them did not only have that BRAF, but also had additional mutations, so changes in the DNA that we know are related with cancer. And we actually found that this has an implication about the prognosis of patients. And what you see on the right is what we call a survival curve. Let me orient you. So on the horizontal axis, you have the time. And on the vertical axis, you have survival. We want the survival to be close to the 100%. That means that the patients do well and they survive. So you can see here that with the black line, when you have BRAF mutations only, patients do pretty well. But then when you have BRAF plus a select subset of mutations that impact a particular pathway, the prognosis is not as good. And that's depicted in the red line here. And this also kind of makes sense that we saw this signal, because these particular mutations that I talked about, that when they coexist with BRAF confer worse outcomes, these are also the mutations that we see in more advanced and aggressive thyroid cancers, like poorly differentiated thyroid cancer that you can see on the left side of this summary of mutations, or even more aggressive anaplastic thyroid cancer. So you're seeing that mutations in PIK3CA that you heard me talk about before, or PTEN, these are enriched in more aggressive tumors. And the other thing that you can see in this study that was done at Memorial Sloan Kettering is that the third promoter mutation, that high-risk mutation that I told you about, seems to be quite frequent in both poorly differentiated and anaplastic thyroid cancer. This does not seem to be as frequent when we're talking about well-differentiated papillary thyroid cancer. Now, we talked about how molecular diagnostics help us understand better the risk of cancer when we're dealing with an indeterminate thyroid nodule. And this clearly has had an impact in a lot of patients. My opinion is that it has had, molecular testing has an even more powerful impact in those patients that have aggressive disease that's refractory to radioactive iodine, that's progressing and requires systemic treatments. And so here you're seeing a summary of all the different mutations that you can have in thyroid cancer, along with the targeted treatment. So we now have the luxury that we didn't have 10, 15 years ago to have targeted therapies, so very precise treatments that attack those specific pathways that each of those tumors likes to be fed with. So for example, when there's a BRAF mutation, we have FDA-approved agents, the dabrafenib and trametinib. If there's a RET-altered thyroid cancer, we have selpercatinib and pralsetinib. If there's NTRK fusions that some of you may have heard at the round table with Dr. Cabanillas, we have larotrectinib and entrectinib, and then there's ALK inhibitors when there's a mutation, the fusion in the ALK gene. So that's very important. And then here you're seeing another view of the thyroid cell. It's very complex, so bear with me. But here you can see the tumor cell, and then you can also see some adjacent cells that also play a role in thyroid cancer. So some immune cells, that's where immunotherapy works, and some endothelial stromal cells. And you can see that there are some agents that are FDA approved for advanced thyroid cancer, like lenvatinib, cabozantinib, sorafenib. These work in several different places and have multiple targets in the cancer cell. Whereas those targeted therapies that I just mentioned, for example, if the RET inhibitors or the NTRK inhibitors, they're more specific and they attack only one of that specific pathway. And that can also have an implication in terms of what's the side effect profile of those more selective treatments compared to the non-selective inhibitors. Now, in the next few slides, I want to show you some emerging data. We're now at the point that we've had a breadth of genomic data accumulated by banking those thyroid tumors, analyzing them with next generation sequencing. And we're now at the point that we can pull this genomic data together with the clinical information and the outcome, the long-term outcomes of those patients. So this slide discusses, shows you a study that was done at Memorial Sloan Kettering, where they looked at patients that had metastatic disease and then received radioactive iodine. And then they compared patients that had exceptional response to radioactive iodine against those that did not respond. And actually there was a difference in the prognosis, the outcome of these patients. So on the left side, you're seeing again another survival curve, and you're seeing that the exceptional responders, the line in red, they do pretty well. The survival is close to the 100%, but then the non-responders did not have such good outcomes. That's the line in blue. And then in the middle graph, you have the makeup of those tumors. On the left side, the exceptional responders, and then on the right side, the non-responders. And one major difference that becomes evident easily is the prevalence of BRAF mutations. That's a BRAF V600. None of the exceptional responders had the mutation in BRAF V600 versus the non-responders had the BRAF V600 in 44% of the cases. Yes.
I'm sorry, I'm not following in the center one. For example, for E1F1 acts, are they? Hi, I'll repeat. I'm sorry. I'm not following in the middle. If somebody has TERT or E1F1 acts, does that mean they're only 33% respond to radioactive iodine?
No.
What are the two numbers next to them?
Yeah, good question. Thank you for asking that. It shows you the prevalence of the mutation in the two groups. So on the left, you're seeing the prevalence of the exceptional responders. Oops. Yes. So here, yeah, so for example, for TERT that you asked about, both groups had a very similar prevalence of TERT promoter mutation, which is surprising, right? So both of them had TERT in 60% of the cases. So they were not really different in that sense. And then when you're looking at EIF1AX, exceptional responders had 33%, 33% of them had a mutation in EIF1AX, whereas much fewer of the non-responders had that. So bear in mind, these are small cohorts, and then that study is it was actually hard to conduct. So these are small numbers, but the researchers really tried to pair these groups and make them as similar in terms of all the other characteristics that the tumors had, besides the fact that one group responded excellently, the other group did not respond.
Would it be correct to assume that if a patient had NRAS, where I see 14% of the exceptional responders, right, had NRAS mutation, but 38% of the non-responders had it, that it seems to be a negative indicator of how one would respond to RAI?
So that's a good point that you're making. I think with this specific study, we don't have a great sample, so we don't have great numbers, and I'm not sure whether the difference between 14 and 38% is what we call statistically significant. So meaning it's not there just by chance. And so I think eventually it's a great question what you're asking. We would need to have bigger studies and more larger studies to understand that. But I feel that the difference in the top mutation, the BRAF V600, you have one group that has no mutation whatsoever. The other group has it in almost 50% of the cases. That seems kind of a more striking difference, in my opinion.
Thank you.
Of course, that's a great comment. And then the other finding in that study, they also looked at the changes in those pairs of chromosomes, and that's the graph on the right here to orient you. Every vertical column is a chromosome, and you have the excellent responders in red and the non-responders in blue. And the squares that are red show gain, so more copies of that chromosome. So what you're seeing is that the non-responders tend to have a pattern where they have gain of an arm of the one chromosome, of chromosome 1, whereas none of that is happening in the exceptional responder. So the take-home message of that study is that non-responders seem to be more enriched in mutations in BRAF V600, and they also seem to be enriched in what we call copy number alterations for chromosome 1. So that seemed to be a distinct feature. Again, these are small numbers, and as we have more genomic data and larger cohorts, hopefully we'll be able to see whether these can be replicated. And then, since we are discussing radioactive iodine, that gives me a segue to talk about redifferentiation. Many of you may already know that redifferentiation is a strategy that we use in tumors that have lost their ability to take up radioactive iodine. So we pre-treat them with an agent in order to make these tumor cells vulnerable to radioactive iodine again. And on the right, you're seeing images before and after treatment with such agent. That's from an NEJM paper from 2013, where that treatment actually worked. And why I'm bringing up this point now is because these redifferentiation strategies have been examined in the setting of clinical trials for the most part. And when you're looking at how these clinical trials were designed, the scientists did take into account what type of mutation these tumors had. For example, I'm looking at the study of Weber here. So the way that the studies were designed, if the patients had the BRAF mutation, they would select treatment with the BRAF and bentrametin, so BRAF-MEK directed therapies. Whereas if there was no BRAF mutation, they would pick trametinib only to show you that it's molecular testing is important, what we call metadata, when we think about approaches and strategies for thyroid cancer. Now, again, another study trying to associate genomic profiles with prognosis and survival. That's a study from MD Anderson in a little bit over 200 patients with anaplastic thyroid cancer. So again, they did genomic sequencing. They found a pattern of mutation that has been described before in anaplastic thyroid cancer, so lots of BRAF and RAS mutations, but also lots of those higher risk mutations like TP53 and PIK3CA. And then they stratified the patients depending on whether they had BRAF mutation or RAS mutation or none. And on the right, you're seeing again another survival curve. Unfortunately, we're talking about anaplastic thyroid cancers, and these curves are not high, closer to the 100% where we would like them to be. The steeper the decline of the curve, the worse the prognosis. And you see this green curve corresponds to the cohort of patients that had the RAS mutations. And these seem to be the patients that behaved worse, unfortunately. So now, what does that mean and how we interpret this? It could be because we now have BRAF-directed therapies for patients that have BRAF mutations, whereas unfortunately, we don't really have targeted therapies for RAS mutant tumors. And this is a high unmet clinical need, and we hope that with clinical trials currently being done, we'll be able to come up with these desperately needed agents. I'll talk briefly about a rare type of thyroid cancer, oncocytic, or else called Hürthle cell. It is very distinct when an experienced pathologist look at this cancer under the microscope, and I'm just showing you a picture on the right, to also make a point that in thyroid cancer, I think we're as good as our pathologists are. You really need a very experienced pathologist by your side to look at these slides. So oncocytic thyroid cancer is very distinct and genomically much more complex, does not behave genomically the same way than papillary or follicular. We're seeing big changes, so either losses or whole doubling of the chromosomes. And then we sometimes see changes in another type of DNA that we call mitochondrial DNA. That's even also complex to look for and requires even more specified sequencing. Another rare subtype of thyroid cancer, we heard also from Dr. Krabainiris before, is the kinase fusion related cancer. So these fusion means that you have two genes, so two pieces of DNA that normally sit far away from each other, but then when fusion happens, those pieces break, and then a hybrid gene forms that contains segments from both of these genes that now come closer together. So these events, so these type of tumors are more common in children and also in cancers that are associated with exposure to radiation. For example, in patients that were exposed to post-Chernobyl radiation. And then an experienced pathologist can also suspect that the tumor may harbor a fusion event because they look different under the microscope. There's a lot of nodule, not just one nodule with cancer. They're spread in the lymphatic and the vessels, and then there's fibrosis, so a distinct feature that you can see under the microscope. And then there's a specific variant, a flavor of papillary thyroid cancer called diffuse sclerosing that seems to be associated with red fusions. And on the picture below, you can see that we are fortunate that we do have targeted therapies for the most common fusions for thyroid cancer, which is great, and patients do well on them. But besides the follicular cell-derived, papillary, and follicular thyroid cancer, we start to know more about the genomic landscape of medullary thyroid cancer, and I'm talking about sporadic medullary thyroid cancer. So in this slide, you're seeing results of a study that was done in a little bit over 200 sporadic medullary thyroid cancers, again, next generation sequencing, where they found that the RET mutation is the most common mutation, which we kind of expected. And the second most common mutation is the RAS mutation. And then when the researchers looked at whether there was association with prognosis, they found that having a RET mutation, actually, those patients had worse outcomes compared to those that had the RAS mutations. And then when it comes to how we are using molecular testing, also ahead, we sometimes have patients on systemic treatments that do well for a period of time, but then they develop resistance to therapy. And molecular testing can really help us identify at least part of the mechanisms of why this may be happening. There may be different explanations underlying resistance to therapy, but one of them, we think, is that the tumor cells try to outsmart the treatment. The tumor cells really want to survive, so then they acquire new changes in the DNA. For example, when patients are treated with RET inhibitors, they develop a new RET mutation that then prevents the drug from binding to the cell, which then causes resistance. And I don't know if there's any, oh, okay. Oh, you have a question? Yes.
Yeah. Sorry. So I was wondering, in terms of the developing resistances that eventually happens, it seems to just about everybody. What do the studies show that have planned drug holidays, for example, with Lenvima or other multikinase inhibitors? Are we able to postpone that point where the cancer outsmarts the TKIs by trying to do that as planned treatment?
I think that's a great question, but I don't believe that we have enough information to know whether holding the medication, if I'm understanding your question right,
Mhm.
or decreasing the dose or doing alternate dosing, whether this has a particular impact on the time frame where resistance may happen.
Okay. Anecdotally, in Facebook groups that I'm in for PDTC and RAI refractory, there seem to be a lot of anecdotes of lenvatinib lasting for quite a while, longer than the median, says it's supposed to. And it seems like people are around that are taking like way less dose, 10, even 4, and to help with the side effects, like 3 weeks on, 1 week off. There's all different variations. It's like it's like the Wild West.
Right. And then
And they're okay for
Yes.
years and years. So maybe we should develop a trial.
I think you're having a good point, and actually Brenna Neufeld, who is sitting behind, will be talking about the side effects of those tyrosine kinase inhibitors. We sometimes pick a dose lowering strategy, or some weeks on, some weeks off, not because we have resistance in mind, but because, unfortunately, as you mentioned, these are drugs that do have significant side effects. And so we want to maintain the quality of life of these patients while also getting clinical benefit from these treatments. So it's also always a fine balance that we're trying to walk with these agents. Great, excellent comment, thank you. And so for the last few minutes of this presentation, I'd like to talk about some broader implications that molecular testing can have. And I'll bring the example of germline RET mutation. So let's give you an example of a patient coming with a thyroid nodule, being diagnosed with medullary thyroid cancer. The next step is to recommend germline testing for a RET mutation. So that means testing whether there's a mutation that's present in all the cells of the body that can be passed to your children for the RET gene. And why that's important? It's important because there's these germline mutations are associated with multiple endocrine neoplasia syndromes, where you not only have medullary thyroid cancer, but you're at risk to develop other tumors in the adrenal gland. So that's another endocrine organ called pheochromocytomas. And that's an information that you really need to know in advance before you proceed with surgery, because these tumors, the pheochromocytomas, produce hormones that can create cardiovascular complications and what we call pheocrisis in the event of surgery. So that, if in that scenario, you would definitely want to know if there's a pheochromocytoma, and you would need to take care of that before you operate for a thyroidectomy. And then these syndromes, there's a flavor and an association of these syndromes with specific mutations, germline mutations of the RET gene. And you're seeing on the left here, I'm just highlighting multiple endocrine neoplasia syndrome 2B, which is distinctly associated with a specific mutation in the RET gene, the 918 codon. And we know that's related to developing medullary thyroid cancer very early on. So this information does not only have implications for the patients, it also has implications for their offspring. So imagine a patient receives a diagnosis. There's a recommendation to test the family members too. And then sometimes those family members, or some of them, may be found to asymptomatically have the same gene. So knowing what specific RET mutation in the germline we have to work with can help create a treatment plan for what we call prophylactic thyroidectomy for those otherwise healthy people that have this mutation. So meaning thyroid surgery before cancer develops, because we know that the cancer risk is going to be very high. And then I'll close by pointing out a couple of clues that sometimes we get from histopathology or genomics to think about testing for mutations for non-thyroid conditions. So a rare subtype of thyroid cancer is the cribriform morular thyroid cancer. It looks different than the other differentiated thyroid cancer. And you're seeing a picture under the microscope here. When the pathologist diagnoses this, the physician is alerted that the patient needs to be tested for a germline condition or inherited condition called familial adenomatous polyposis. So this has nothing to do with thyroid cancer itself, but it does predisposes patients to colon cancer. So if a patient is found to have that, they need to have a colonoscopy. Usually, if you have this condition, you may have hundreds or thousands of colon polyps. So this obviously has significant implications, not directly related to your thyroid cancer that you're probably going to do very well with. And the last plug here is for DICER1 mutations. So sometimes we find those in thyroid nodules, either benign or malignant. If we do find them, we would recommend testing for a germline DICER1 mutation because we may find that the patient has that change, which is associated with a syndrome, but not only has thyroid tumors, but also tumors in the lungs, the ovaries, the kidneys. And so I'd like to wrap up this session and hopefully answer any other questions. I hope that I was able to convince you that molecular testing is a very powerful tool. It helps us in diagnosing indeterminate thyroid nodules. It informs prognosis in thyroid cancer. It can guide us select the most precise treatments. And when we're dealing with advanced and progressive disease, it is an important tool as we try to identify the mechanisms of why resistance to therapies happens. And then in select scenarios like the ones that I presented, it can help us cancel patients for other conditions that are not thyroid related. Thank you so very much, both you in the room, but also on Zoom. Happy to take questions. Yes. And I don't know if we have anything on the from the Zoom participants.
I didn't see RBM10 or JAK2 on your list. Are those less frequent or we don't have any data?
I think you're one of the most informed participants in this session by talking about RBM2 and JAK2. So we don't have much data. These are not frequent genomic events. We may have some hints about what their presence confers, but that's where bringing in knowledge from the clinical cohorts, but also from translational and basic scientists. For example, the work that Dr. Fagan is doing at Memorial Sloan Kettering, studying specific pathways in cell lines and mouse models, gaining information from those preclinical systems is very important in really understanding what each mutation on its own does in cancer.
Thank you.
Thank you.
First, I want to say thank you for doing the presentation and for informing us. Also want to say that I think the molecular testing is great, and I wish they had that, like more people would do it, because I actually have a friend that she had done 2 biopsies and she had a total thyroidectomy and then it was benign. So she doesn't have a thyroid now and she never had thyroid cancer. And in my case, my first biopsy, it was indeterminate. And they're like, oh, we'll just monitor you for a year or whatever. And then a year later, when I did it again on the Bethesda scale, I had a 6, and it had already broken out of my thyroid capsule. So it would have been great to have had that done before. In my case, they did the molecular testing of my thyroid a year later, almost. So I do have the BRAF. So my question with when you were talking about the redifferentiation is, how long does a patient need to be on treatment for, like, I guess if for the redifferentiation to work? Because, for example, I've done 2 RAI treatments and they haven't really worked. So I'm curious, because I think that I'm probably now, from everything I'm seeing, that if a person does have BRAF, that maybe it doesn't really work.
So Yes, and on the first comment that you made, we are very fortunate that molecular testing is becoming more and more widely available to better understand and stratify those iffy results from indeterminate thyroid nodules. On the question about redifferentiation, this is a strategy that is being done primarily in tertiary academic centers and within clinical trials. So with regards to the question on how long the patient needs to be, this is usually dictated by the way that each clinical trial was designed. So sometimes it could be 6 to 8 weeks. And then there are still some questions that are open for us to answer too about how to understand if these directed treatments will benefit the patient. So we may do a diagnostic scan before we administer the radioactive iodine, but then we also gain more information by doing those post-treatment scans. So those whole body scans that happen after a patient has received a higher therapeutic dose of radioactive iodine. And we may actually Sophie Leboulet from Europe has done the trial with redifferentiation with dabrafenib and trametinib and has seen that there is a change and an increase in the uptake of iodine when you compare the diagnostic scans and then the post-treatment whole body scans.
Another question, just how can somebody participate in where do you get information to know that there's a clinical trial to see if you could even participate in one of those trials?
I think that first of all, the best person to contact is your medical professional, so your clinician, and then I believe that ITOG and the ATA have plans to kind of put more information on the website so that patients are informed about the active clinical trials.
Thank you.
Of course, thank you.
Hi, I have a question regarding oncocytic carcinoma. What is the value of molecular testing in that situation? Because loss of chromosomes you cannot treat, mitochondrial mutations you cannot really treat.
Great question with a not clear answer at this point. Oncocytic thyroid cancer is one of the most challenging in terms of the genomic makeup tumors. Dr. Gandley at MSK is conducting very important translational work to better understand the genomic makeup of those tumors. I think this is still an open question that we're actively researching. So if there's no other questions, I'd like to very much thank you all for coming in today. It's a pleasure to attend the ThyCa. Enjoy the rest of the day.